Oh, okay. It says recording in progress. I think we're doing it. Hi, everybody. Okay, so thanks for coming. Bear with me. This is my first time doing a PowerPoint lecture on Zoom. And I'm sorry that we can't do this in person. As many of you know, I like to have more of a conversation than a lecture type rounds, but since we've been so busy and parking is so limited, we thought this would be the best way to reach as many people as possible. That being said, if you have questions or comments as we're going through, and Karen, if you have things to add, please just unmute yourself and pipe in. I'm happy to make this as much of a conversation as we can via this format. So we're going to talk today about stabilization and monitoring of the critical patient. And the idea here is, obviously we have a lot of new people, and many of us like to review, but as we have been busy over the last couple of years and seeing a lot more patients, triage has become a lot more important. And so it's important to understand the basics of how to do that. And then also some things that you as technicians and assistants can do to help us work as a team and get these patients stabilized as quickly as possible. Okay, now it won't let me advance. Hold on. Oh, there we go. Okay. So as you guys know, it was just Vet Tech Week recently, and I just put this slide in to say thank you for everything that you do to help us as a team every day. Obviously, veterinary emergency and critical care is not an easy job, and it's not something that we can do by ourselves. So we very much appreciate everything you guys do, and I think we all feel really lucky to work with such a wonderful team. I know you guys are the reason I come to work every day. Triage. So this is one of my favorite topics to talk about. Triage was developed really in the mid 1800s on the battlefield when there were mass casualties and mass injuries, and people needed to be able to prioritize treatment of injuries on the battlefield. And so the idea was to be able to sort patients out based on level of priority. So the most critical patients should be treated first, and then patients who are stable should be able to wait until those more critical patients are stabilized. The idea here really is that it should be a very quick, 30 to 60 second brief assessment that is really just verbal and visual, and you shouldn't need any instruments to do a triage. You don't need a stethoscope, you don't need to get a blood pressure. You're really just getting some information from the client and then also taking a look at the patient to see if you can determine if they need to come back and be assessed by a doctor right away. Based on the literature, there's really 9 components of triage. So 2 of them are verbal. So the first one is the presenting complaint. And I think many of us handle this in a fashion of, going up when there's a call for triage and asking the client, what brings you in today, or what's going on with your pet today, and trying to get a basic idea of what has brought them into our emergency room. And then in conjunction with that, it's also important to know when the pet was last normal, right? So for example, a cat that has been vomiting chronically for 3 months, maybe on and off, may not have the same level of urgency as a cat who has been acutely vomiting 9 times over the course of the day because the owner fed him some almonds the other day. And then while you're getting that information from the client, I also like to kind of be taking a look at the patient, right? So if it's a dog that's up front or a cat that's in a carrier, you're kind of talking to the owner, and then also at the same time looking at the patient and assessing these basic 7 things. So you want to see if you can assess their mucous membrane color, keeping in mind that pink is normal. And anything that's abnormal should probably prompt a triage to the back. So if they look pale, that could indicate that they may be anemic. If it looks like they're cyanotic or kind of a bluish color, that may indicate that they're hypoxemic or they have low oxygen levels in their blood. If they look icteric or yellow, that can indicate either a hepatic problem, they have a liver dysfunction, or they may have hemolysis where their red blood cells are being destroyed. And if they look muddy, especially cats, that can be an indicator of both sepsis or sometimes methemoglobinemia, which we can see with things like Tylenol toxicity. While you're looking at their mucous membrane color, it's also good to assess a CRT or capillary refill time. So I know all of you know how to do this, but in order to do that, we lift up their lip, like you can see in the picture, and then briefly just depress their mucous membranes and watch how quickly that color refills. The idea there is that in a patient with normal perfusion or normal blood flow to their tissues, it should take less than 2 seconds for that color to come back. If it comes back more slowly, that can indicate that they are hypovolemic or hypoperfused, so they may not have good blood flow to their peripheral tissues. Or if it comes back really rapidly, that can indicate that they may be vasodilated, they may be hyperthermic, something may be happening that's making those vessels more dilated than normal, and that blood flow is coming back more quickly, and that can be abnormal as well. Knowing normals is important here, obviously. So heart rate or pulse rate in assessing during triage, I think many of us like to do that by palpating the femoral pulse. You can also palpate the dorsal metatarsal pulse, remembering that cats tend to have a faster heart rate than dogs and are probably going to be closer to a 160 to 220 range. Dogs are probably going to be more in an 80 to 120 range. And tachycardia, so high heart rates, or bradycardia, low heart rates, would both be reasons for us to assess those patients more fully if things are abnormal. While you're feeling the pulse, obviously you're also going to be able to tell the pulse quality. So hopefully you can fairly easily find a pulse on a patient, but if you're having trouble finding a pulse, or if it feels like their pulses are weak, that's something that's going to prompt us taking a look at them and wanting to probably get a blood pressure.
Hey, Carrie, can I interject for 1 second?
Please.
So on that topic right there, the only other thing is when you're assessing that pulse pressure, if the history is that it's a Great Dane and the dog collapsed or something like that, remind you, slide your hand down on the side of the dog's heart. I've had a few these AFib dogs in with severe pulse deficits that, we recorded a heart rate of 80 and I get them in the back and it's 300. So the history figures in on that one for some of those pets. And I think I've had that happen to me twice in the last 6 months where, we kind of left one of these severely tachycardic dogs sitting in the lobby because they looked okay and their pulse was decent. But that's where the history kind of comes into play there.
Absolutely. That's a great point too. And if you can even like Dr. Fidel said, put one hand on their chest to assess their heart rate and your other hand on their femoral pulse region and just make sure it seems like they're synchronous. We do see a lot of patients that have arrhythmias, and so you may catch something like dropped beats there too. Good idea. Respiratory rate and effort are obviously important, keeping in mind that many of the patients that come into the hospital to see us are stressed. And so dogs may be panting and patients may be breathing faster than normal, but an increased effort to their breathing, using their abdomen to breathe, breathing with a really short, shallow respiratory pattern, or cats breathing with their mouths open are always things that should be triaged to the back to take a look at them. And I don't know if you guys can hear my cat howling. I'm really sorry. In the background, she's 18 and she's totally deaf. So she's screaming. The last thing is mentation and level of consciousness. So, obviously patients coming in should be fairly bright and alert and responsive to us if it seems like their mentation is abnormal, if they're dull, if they're depressed, lethargic, if they seem like they are not responsive to their surroundings appropriately. Those would all be reasons for us to take another look at them. And then usually the one additional thing that I add on this list is the urinary system. We see a fair number of blocked cats. And so just getting information and making sure that the patient is able to urinate is good. And also just doing a brief palpation of their bladder, especially if it's a kitty and you're suspicious, is a good idea too. One of the things that we have been doing more, obviously, during and post-COVID is phone triaging. So if you're working in the lab or the emergency room and you guys are taking phone calls and trying to determine if patients need to come in, obviously you can always talk to the doctor on duty to try to get more information and, help to make a decision for that owner. But some of just the basic things to think about that are helpful to us when you come and ask us are, it is wonderful if you can get a signalment of the patient. So that includes their age, their sex, and if they're male or neutered, and their breed. And when you come and talk to us and say, hey, I have a 6-year-old neutered male lab who's doing X, Y, and Z, that may change the things that we think about in terms of urgency or possible problems. So if you can get that information from the owner, that's helpful. And then presenting complaint and last normal, like we talked about for a regular triage, is helpful too, because chronicity can be critical to whether or not we need to see a patient right away. And then general symptoms like vomiting, diarrhea, coughing, and sneezing. And again, if they're able to urinate. Obviously, you can always collect more information if you have further questions, but those are the basic things that we're going to want to know in terms of making a decision if they need to come in. In general, any of the abnormalities of those triage systems, so the respiratory system, the cardiovascular system, the neurologic system, or the urinary system, are things that would constitute an emergency and prompt us to have an owner come in or to bring a pet to the back. But there are also some kind of other things where a patient may not necessarily look critical or unstable in the waiting room, but we would probably want to take a look at them sooner. And that would include any kind of trauma. So a dog, for example, that has been hit by a car that maybe looks okay, but could be having some internal bleeding that we're not seeing right away. We always want to triage those so that we can at least do assessment and make sure they look stable, and then they can always go back up front and wait with their owner. But we want to take a look at those guys. Any kind of intoxication, time can be really critical for those, because we want to make sure that we are starting decontamination procedures as quickly as possible. So we want to see those fairly quickly. A patient that has had seizures, even if they look normal in the emergency room, we're going to want to take a look at pretty quickly, maybe get a blood sugar, maybe get a catheter in just in case they have another seizure. Anything that's actively bleeding, so that we can get it covered up to try to prevent contamination, and then also just make sure that those patients are stable and don't have bleeding in other places. Severe pain, so patients who have abdominal pain, or maybe a dog that got hit by a car and is referred over with something like a fracture that is stable, but we want to make sure that those patients have adequate pain management on board fairly quickly. And then things like dystocia or other abnormalities of the urogenital system are also things we're going to want to take a look at and make sure any puppies or kittens are stable, and see how quickly we need to intervene if it is a dystocia. Anything to add to that list, Karen?
Nope, that covers it.
Okay. I always laugh too and tell people, owners that are being crazy, you can always triage those pets to the back if it's going to give an owner peace of mind to let us know that we're at least doing a triage exam and making sure their pet is stable, or putting them in a room so that we're not creating a ruckus in the waiting room can be helpful sometimes too. So once we get these guys in the back, I wanted to talk about a few things that we can do to kind of start initial stabilization, especially when we've been busy lately. It's really nice if you, as veterinary technicians and assistants, can get some things rolling, maybe while the doctor is working on another patient or in a room talking to an owner. We never will object to having more information about a patient, as long as it's not compromising the stability of that patient. So we're going to talk about a few things that you can potentially get started, and also how those things work, so you have a good understanding of why we do them. One of the most important things here is we do want to be fairly quick, and we also want to minimize stress to the patient, especially if they're unstable. We've all seen these patients who come in and they don't look too bad when they come in the door, and then pretty quickly, within 5 or 10 minutes of being in the hospital, they can decompensate pretty rapidly, and stress can play a big role in that. So not only do we want to try to remain calm, but we want to try to get things done quickly for them so that we can start to get them stabilized and figure out what's going on. If you have the capability to get a full TPR, obviously that's always helpful. You're kind of going to have an idea, hopefully, of pulse and respiratory rate already, but temperature, if the patient will tolerate it. Auscultation, by yourself or the doctor. It's always good to practice auscultation. And if you guys want examples of things, come and find us when we're working, and practice listening to patients, because picking up things like murmurs or abnormalities in their lung sounds can be really helpful, especially as you're taking care of patients over a 12-hour shift. Recognizing those changes can be really helpful to your doctor. Getting more PE information if it's safe. So doing a complete physical exam if the patient will tolerate it, and then eventually we'll get full historical information from the owner as well. And if a patient is unstable and needs a break, that's okay. Let's move them into oxygen, or provide oxygen if necessary, or give them some sedation or pain medication, and then move on. Obviously, in many of these patients, we're going to be placing IV catheters. And I know a lot of you are really comfortable with that. One of the things that we think about a lot is where should we place these IV catheters? And there was an interesting study that was done a few years ago at Tufts where they looked at placement of peripheral and central catheters and how quickly fluids would be delivered based on different locations. So I think in the majority of situations in an emergency situation, we're probably talking about cephalic vein placement of catheters. And the idea there is that it is a little bit closer to the central circulation, meaning the heart, than the back leg. And we're usually not going to go for jugular catheters right away on these patients. We don't know what their coagulation status is. We want to try to not draw blood from the jugular veins if we can avoid it. So probably either a cephalic catheter or a saphenous catheter is where you're going to go initially. Certainly, if they're going to need bolus therapy, bigger catheters are better. And bigger, shorter catheters are usually better for boluses. I know for kind of long-term catheter placement, we talk more about using the longer catheters. But a large bore short catheter is going to allow you to deliver fluids as quickly as possible. So in a big dog, you're going to probably want something like an 18 gauge. For most of our kitties or smaller dogs, we're doing 20 gauge or 22. Very, very rarely, I would say you need something like a 16 gauge catheter in a peripheral vein. So I would not stress that. I would probably say 18 is sufficient for anybody who needs fluid boluses. Oxygen supplementation is also something that we'll think about in a lot of these guys. And obviously there's a lot of ways to do this. This is probably not the easiest way, but this was a demo unit we had during my residency to supply oxygen to cats when we were working on them. They don't like it, believe it or not. So not something we use very regularly. Oxygen cages are great. The caveat there is that once patients are in an oxygen cage, just keep in mind that every time you open the door to work with them, that oxygen is going to go down to room air. So if they need to go in there for initial stabilization and kind of take a break, that's fine. If they're hospitalized in their long-term, that's fine. It's just important to remember that it is not necessarily a continuous source depending on how much you're working with them. We use nasopharyngeal and nasal oxygen catheters a lot, and these I think are wonderful. They do allow us to work more easily with the patients. Most of them tolerate them pretty well. There are some conformation restrictions, so obviously really brachycephalic patients can be challenging for these, and they're not an option for cats. But for most of our medium and large size dogs, this can be a really nice way to deliver oxygen. If you're not comfortable placing these or aren't familiar with how, find a friend on your shift who can help you learn how to do it. But the nice thing is that you really can just numb their nose with a little bit of proparacaine and lidocaine. And then we want to measure to the lateral canthus of the eye. And that's about where you want to place your catheter too. Sometimes they need a little bit of sedation to do it, but most of them tolerate them very well. And you can deliver fairly high flow rates this way. And a lot of our bigger patients can be comfortable with these. And it also helps us avoid things like hyperthermia in the oxygen cage. In the future, we're also looking at getting some high flow nasal oxygen. So hopefully that's something that's going to be coming to us in the next 6 months or so and is going to allow us to deliver higher flow rates to patients more comfortably over time too. Obviously, in the short term, when you guys are in the emergency room, flow-by is a really nice option for oxygen. Usually here we're talking about FiO2s of about 25 to 40%. Keep in mind that room air is about 21%, so it may not give them a huge amount of oxygen support, but it can certainly help to stabilize them. And I see a lot of people kind of just holding the oxygen line up to patients' faces. When you're doing that, if you're not within about 1 centimeter of the nose, that's going to diffuse into the air pretty quickly. So I do like to put a little mask on the end, not that you necessarily need to put it all the way on their face. And you certainly don't want to put it all the way on their face so that they can't exhale because they're going to get hot and CO2 is going to build up in there. But it does help to just concentrate the oxygen a little bit better. And I think we get slightly higher FiO2s by doing that. So in addition to catheter placement and fluids and oxygen, we're probably also going to start running some diagnostics on these guys pretty quickly. And it's typical for us in the emergency room really to say, you know, pull what blood you can, and we're probably going to end up running a full panel. But in patients who are critical or really small patients, or patients where maybe we're waiting to talk to owners and can't get all of the blood right away, we're going to talk about using a minimum database to do a brief assessment, and then also electrocardiogram to assess arrhythmias, pulse oximetry to assess their oxygenation, and then blood pressure too. The minimum database by definition is a PCV in total solids, a blood glucose, and a blood smear. And I'll add to that I really like having an EPOC, which is a venous blood gas. It only takes just a teeny bit of blood. We can run it really quickly and it gives us a lot of information. So we're going to talk about that too. PCV solids, I think, gives you a huge amount of information with just a couple of drops of blood. It's nice, right? You don't have to pull a lot of blood. It's really cheap and easy. And I will stress any patient that we're doing blood work on in the emergency room and in ICU, as you guys probably know, we want a PCV in solids with almost every sample. And it's really important to measure both of those things. So the example that I use to stress that is, you know, if we have a referring vet on the phone or a technician on the phone who says, I'd like to refer a dog who's anemic, its PCV is 17. Okay, cool. Knowing the total solids is going to give me a ton of information about what's going on with that patient. So if the PCV is 17 and the solids are normal, which is usually between about 5 and 7, that's going to make me think less about blood loss, because usually your solids will also be low if you're actively bleeding or you've had bleeding, and more about things like hemolysis or a chronic anemia. So it helps me think a little bit about how critical the case might be, but it also helps me start to think about formulating my differential list and what might be going on with this patient. There's 3 major causes of anemia that we think about. So blood loss, as we said, where you're losing both protein and cells. Decreased production, where your bone marrow isn't making red blood cells, so your solids should be normal in those situations. And then destruction, like an IMHA, where you have a hemolytic process and the red cells are being destroyed, and the solids will be normal in that situation as well. One thing that I think that we see fairly frequently, and this is pretty cool, the body is amazing, is that in cases of really acute hemorrhage, so, you know, a dog that got hit by a car, a dog that has a ruptured splenic mass and is coming in and is actively bleeding, instead of those patients having low PCVs and solids right away, we'll usually see that they actually have a normal to sometimes even a slightly high PCV and a low solids. And the idea there is that in cases of acute hemorrhage, the spleen contracts in the body and it releases additional cells into the circulation. And so that will bring the PCV up and kind of falsely elevate it temporarily before it starts to drop again as bleeding is ongoing. So if you see that, you know, you have a golden who comes in and he's got a hemoabdomen and you're looking at his PCV and solids and it's 37 and 4.5, that does indicate that he's probably bleeding and you're going to see that PCV drop. So it's good to be prepared for that. Just to talk a little bit more about potential differentials for changes in PCV and solids. If you see a high PCV and a low solids, like we said, you may be seeing a bleeding patient. High PCVs can also indicate hemoconcentration, so really dehydrated patients. We had a dog who was in just a couple of days ago, Isa, that sweet little beagle in the ICU, who had a ruptured gallbladder, and she came in with a hematocrit of about 58, probably due to dehydration and hemoconcentration. And then also often patients with HGE or hemorrhagic gastroenteritis, where they have really bloody diarrhea, we'll see them have a low solids because they're losing some protein in their GI tract, but they're also very hemoconcentrated because they're dehydrated. If both of those things are high, often we'll see that secondary to dehydration as well. So kind of where fluid is shifting can differentiate those things. And then if you're seeing high total solids, so higher than 7 in a patient with a normal PCV, we think about things like chronic inflammation, elevated globulins or albumin, which we can sometimes see with neoplasia, FIP in kitties, and multiple myeloma too. So those can all be really valuable little things that we can get just from this very small amount of blood that really helps us to formulate some additional differentials for a patient. It's also important to look at the serum. So when you're running those little PCV tubes, just take a look and make sure that it looks fairly normal. It should be pretty clear. If it looks icteric like this sample, again, that's either going to indicate hepatic hyperbilirubinemia, so they have a liver problem, prehepatic hyperbilirubinemia, so they have something like a hemolytic process where their cells are being destroyed, or post-hepatic disease, so something like a gallbladder obstruction that's causing them to look icteric. If it looks hemolyzed, that may just be a sampling effect, but we can also see that with IMHA and red blood cell destruction. And if it looks lipemic, that's important to note too. It may indicate other changes in the blood work. It may indicate a recent meal. We can see it with some kinds of toxicities or some kinds of treatments that we provide. So often we'll see that when we do lipid therapy in dogs, we're monitoring samples for lipemia to see if we can continue therapy in those guys.
And if you guys notice that the solids are a different color, make sure you note it on the lab form, because it affects sometimes how we interpret some of the blood results. Will be affected by hemolysis in particular.
Yeah, good point. Blood glucose. So obviously we're often getting sugars on our epochs or on our chemistry panels, keeping in mind that if those samples do sit and we maybe have clients who are waiting to make decisions about continuing care, getting a BG initially can help. Obviously there are cases where we're going to do this like puppies or neonates or seizuring patients, but these glucometers are really nice. They're cheap and easy to use. You only need a teeny drop of blood. You can also use serum or plasma for most of these machines, with the caveat that some of these values are going to be lower than serum glucoses in both dogs and cats. So, and the same is true in people. There's kind of a safety mechanism built into many of the glucometers where they tend to read lower than a person's normal sugar as a trigger for people where, you know, if they're diabetic and their sugar is dropping, they want to know that they may be trending downwards. So keep that in mind. And if you're getting a funny sample or a funny result, which we sometimes do, you can always check it on the Catalyst or an epoch. It is not uncommon to see hyperglycemic patients that come into the emergency room. We would define that as about greater than 180 in dogs, about greater than 220 in cats, keeping in mind that cats can get really stressed and we can see profound hyperglycemia in them when they're sick. In both of these species, stress hyperglycemia is common. We also see profound hyperglycemia in cases of trauma. And then obviously if the patient is diabetic or having a complication of diabetes, that could be a trigger as well. Usually in most of these patients, we're not going to treat their hyperglycemia right away with something like insulin. We're going to give them fluids and reassess them and then decide if the hyperglycemia is persistent, if further treatment is needed. Hypoglycemia is a different story and needs to be treated quickly. In the literature, that's defined as less than 60 in both dogs and cats. And things like sepsis, insulinoma, some toxicities, and insulin overdose in a diabetic, Addison's disease, and neonatal hypoglycemia would be common causes that we would think about. And this is something that we want to treat quickly. We have a lot of clients, I think, that when we're talking to them about hypoglycemia, they'll say, oh, well, Fluffy hasn't been eating, you know, in 24 hours. And if Fluffy is an adult animal, adult patients in general do not become hypoglycemic from anorexia. So if they're hypoglycemic, there is another problem there. The most emergent thing that we would worry about would be sepsis, but certainly there can be other causes, and it's something that we want to investigate further. We don't want to just write it off as secondary to anorexia. When we treat hypoglycemia, we're usually giving them a dextrose bolus. And when we talk about these doses, they're in grams per kg, not mgs per kg. So that's a good math thing to just keep in mind. And we do give 50% dextrose. So you want to make sure that you're diluting it according to your doctor's orders, usually either 1:1 or up to 1:4. And you want to give it kind of slowly. I have here over 5 to 10 minutes, but even over, you know, a 2 to 3 minute slow push is usually okay. And then also keep in mind, after we treat it, we want to make sure that we recheck a sugar to make sure that their sugar is coming up. And we're probably going to need to follow that with some kind of dextrose supplementation in the fluids in most cases. So don't let us forget about that. Sometimes, we'll say we'll order a bolus and then we're doing other things. So make sure you ask your doctor, hey, do you want some dextrose in the fluids, or when do you want me to recheck a sugar?
One more thing, a 0.5 gram per kilogram, which is the usual dose that we're using in the ER, is 1 cc per kilogram, just as a little short caveat, so you don't have to do any major math if you're trying to hurry.
Awesome. Usually when we're supplementing dextrose in fluids long-term, we're talking about maybe 2.5 or 5% supplementation. If we're getting higher than that, we do need a central line. Dextrose can be very hyperosmolar at higher concentrations and irritating to the tissues. So if you have a patient that has persistent hypoglycemia and you need a central line, let us know. We're always happy to help with that too. The other parts of a minimum database technically include the ASO stick, which I think, really is not something that we use, given the access to so many other diagnostics that we have. So I'm not going to talk about that too much, but I do think that blood smears are really valuable. And I know that you guys, when you're working in the lab, do a lot of blood smears. They really do provide us with a lot of valuable information, especially in small patients where maybe if we can't get a full CBC, or how the CBCs go, and it seems like the platelet count is coming out low on the automated count, we're going to want a smear to look at the platelet count and make sure that's okay. So it never hurts to practice making smears if you have extra blood, and if we don't need it, it certainly never helps to practice looking at them either. We can look at both red and white cell morphology, we can confirm those counts, we can confirm platelet counts, and we can look for things like agglutination. Just to give you a little example of this, this is for Alicia. This is a dog who came in a couple of years ago who had an anemia, and he was a pity, and he had been from, I think he was from somewhere down in the Carolinas. And so just doing a minimum database and a blood smear on this guy allowed us to take a look at his red cells. And does anybody know what this is? If anybody feels like chiming in, see anything funky? So there's these little organisms within the red cells that we say look like a ring with a stone in it. And that is very typical for babesia, which you can see most commonly in pit bulls because it can be spread through dog fighting, but it is a cause of hemolysis in dogs, causes red blood cell destruction, and can cause anemia. So that's a really cool thing that you can find just by looking at a blood smear. Okay. Just to talk briefly about the EPOC, I know we run these all the time, and there may be a lot of parameters on here that you guys are not necessarily familiar with. But this used to be part of our minimum database during residency, and is something that we order really commonly daily on our patients in the ICU, because like I said, it does take just a really small amount of blood and it gives us a huge amount of information. So it provides us with acid-base status. So it tells us about their pH, their CO2 in their blood, and their bicarbonate in their blood. It tells us their electrolytes, so sodium, potassium, chloride, and ionized calcium. It tells us their glucose. It tells us their BUN and creatinine on the blood gas analyzer that we have. Not every blood gas analyzer has that, but ours does. And then it tells us lactate, which is my favorite, because I'm a dork. But I think lactate is such a cool indicator of volume status in dogs and perfusion. So the idea here is that if you have a patient who's hypoperfused and they're in shock and their tissues are not getting adequate oxygen, those tissues are going to switch to anaerobic metabolism. And when that happens, lactate is a byproduct of anaerobic metabolism. And so if your lactate is elevated, that can be an indicator of poor perfusion and can be something that you can trend over time as you resuscitate the patient. And this picture is from when I worked at Penn. My residents had a contest to find patients who had the highest lactates, and they had to take selfies with them. So this dog had a lactate of 18 when he came in. He was hit by a car. And over time, as we resuscitated him and monitored his lactate, you could see that number coming down. So you can use it as an indicator that you're doing a good job and that their perfusion is returning to normal. Any questions about blood gas stuff, minimum database stuff? Anything? Okay. So next we'll talk a little bit about ECGs. I know that these are sometimes the bane of your existence, but they can be really helpful for patient monitoring and for initial assessment. So the idea here obviously is that the ECG assesses the electrical rhythm that's generated by the heart, and it's sensed at the body surface. So there are a lot of different situations where we may use it. Like Dr. Fidel was saying, if you're sensing an asynchrony in the heart rate and the pulse rate, that could indicate arrhythmias, and that would be an excellent indication to get an EKG. If you have a patient who comes in with a history of collapse or weakness, and we're looking potentially for a cardiac cause, that would be an indication to do an EKG. Most cases of trauma, I would argue, are nice to do an EKG on initially. We can see traumatic myocarditis, especially in dogs, where they can have arrhythmias because of blunt trauma. And so that can be nice to get an initial assessment. And then I really like it too for monitoring during resuscitation. If you have a dog or cat who's fairly down and out, who, you have done your initial assessment on, and we've gotten some blood work and we're starting therapy, we're giving fluids, that kind of thing, and you're maybe across the room now working on another patient, it can be really nice to have an EKG on them so that you can use it for monitoring, and you can kind of keep an eye on what's happening while you're doing something else. That little gallbladder dog we had this weekend who we were covering in the ICU, it was great. We put her EKG on and she was down on the floor, and Michelle and I were kind of doing other things, but we could look over and see if she was getting tachycardic, and then, have a conversation and say, do we think she needs a fluid bolus? Is she getting painful? How do we need to intervene? Because she may not look different on the surface, but something's changing that we need to be aware of. Usually for these, when we're getting a brief assessment, we're talking about 3 bipolar limb leads. Ideally, if you can, you want to have the patient in right lateral recumbency, and you want them to be, laying down all the way with their limbs kind of out 90 degrees from the body to try to get the most accurate tracing. And then we're going to attach those little leads to the caudal elbow and the stifle. Pick the rhyme of your choice. Many of us went to Michigan State, and so we learned green and white is always right, and Christmas comes at the end of the year. So the white goes on your front right, and then the red lead goes on the back leg. But there's a whole bunch of different ones, and if you need a little mnemonic, ask some of your colleagues and they can come up with something. And then, like I said, we have this kitty who we're fluid resuscitating or monitoring, and we have an EKG next to her, and we can watch it over time. Obviously, now we also have telemetry, which is great for a lot of these patients, and we can watch them a little bit more remotely with the leads on. But in a case of acute resuscitation, it's fine to just use the alligator clips so that we can monitor them before they get admitted and moved into the ICU. Pulse oximetry, as we all know, is the tool we love to hate. When it works, it's wonderful. When it doesn't, it's a pain in the butt. But it is a really neat little device. So the idea here is that the pulse oximeter assesses oxygenation in the tissues, and what it's actually measuring is it's measuring the percentage of our hemoglobins that are saturated with oxygen. So that percentage number is that. The probe ideally is attached to some kind of non-pigmented skin or mucous membrane, because it needs to assess flow in a blood vessel in order to work. And then the wavelengths that are traveling through that little red light that you can see, that infrared light, reflect the percent of oxygenated hemoglobin in the blood. So a normal pulse ox would be anywhere between 95 and 100%. And because of the way this oxyhemoglobin dissociation curve works, very small changes in the pulse ox, very small drops, actually indicate huge changes in tissue oxygenation. So the idea here is that if you have a patient who has a normal PaO2, a normal concentration of oxygen in their blood, that should be about 90 to 105 in most patients. And so if we go up here to our curve, their pulse ox is going to be reading about 95 to 100. This curve goes on to the right because if you have a patient on oxygen who's anesthetized and intubated or who's on flow by, their tissue oxygenation will be higher, their PaO2 will be higher. They have more content of oxygen in their blood. Obviously, they're fully saturated, but then they can also have free oxygen in their blood. And their pulse ox is still going to be 95 to 100%, right? You can't be over 100%. But as your oxygenation starts to drop, this curve actually starts to drop off pretty precipitously. So if your pulse ox is reading 90, that's actually a tissue oxygenation of about 60, which is actually really severe hypoxemia. We say that if you have a pulse ox of 90 despite being on oxygen, that's kind of actually our cutoff for intubation and mechanical ventilation. So often on our call orders, we'll say, you know, notify me if the pulse ox is less than 94 or if it's less than 93, because we want to know if patients are trending downward there and we need to intervene further. This is also the reason that we'll ask people to get pulse oxes off oxygen, right? Because if you're on oxygen and you're pulse oxing, well, that's great, but we want to know what your lungs are able to do off of oxygen and make sure that you're responding to the oxygen that we're providing and hopefully improving as we do that. Obviously, the pulse ox is a really finicky tool. And so if you can get it to work, great. The thing that you want to make sure when you're using it is that their pulse rate matches the pulse ox. If it doesn't, or the pulse ox isn't reading, or you're getting a crazy number, it's probably not accurate. And I always tell people, if you can't get a reading, don't let it change your plan. If your patient is breathing like this, they need to go in the oxygen, even if it says their pulse ox is 100. So, keep in mind the value of the tool in combination with what it's telling you and what your patient looks like. Non-invasive blood pressure monitoring is the last thing that we do really commonly for these patients as we're stabilizing them. And there's a couple of basic ways that we do that with the Doppler blood pressure and the oscillometric blood pressure. So we're just going to go through both of those briefly. Direct arterial blood pressure is the gold standard. And the idea here is that you're actually putting a catheter into the dorsal pedal artery. This is Brody, that barium dog from last week. That everybody worked so hard on, and Laura was able to get an arterial line into him so that we can use that for direct blood pressure monitoring. We're trying to do that a little bit more because it is really valuable. It gives you a tracing on the SurgiVet machine so that you can actually measure their blood pressure in real time. But obviously, in order to do that, patients need to be down and are usually either under anesthesia or recovering from severe illness, and we're able to do it because they're not moving around very much. Normal blood pressures for patients in the hospital are about, I would say, 120 to 150 in dogs, and about 115 to 135, 145, maybe a little bit higher in kitties. The mean blood pressure is important too, because we consider that their perfusing pressure. So a mean blood pressure that's less than about 90 indicates that the kidneys especially are not getting good perfusion. So we want to make sure patients have normal blood pressure. And if they don't, then we're acting aggressively to bring their pressure up so that we can make sure their tissues are getting good perfusion. In terms of causes of low blood pressure, there's, I think the major thing most of us think about is hypovolemia. So the patient needs volume. They don't have enough blood in their cardiovascular system to provide good blood pressure. But other things that may play a role would be something like heart failure, where you have plenty of volume or sometimes too much volume, but that volume is not going in the right direction to provide adequate pressure. Arrhythmias, so they may have an adequate heart rate, but they may not be perfusing with all of those beats. And then things like peripheral vasodilation. So they have plenty of volume in their system, but their peripheral blood vessels are really vasodilated because they're septic or have systemic inflammation or have heat stroke. And so those vessels can't constrict normally and maintain blood pressure. Hypertension is, I think, something that we do need to be a little bit more aggressive about in general in veterinary medicine. We see a fair number of patients who have blood pressures over 160. When you start to get over 180 or so, we do worry that that's going to have systemic effects. It can affect their retinas. It can long-term cause blindness. It can cause them to have problems with their kidneys, and can sometimes even affect the heart and tissue oxygenation. So usually in patients that are hypertensive, we're talking about stress and trying to manage that stress. pain and trying to adjust pain, and sometimes also underlying disease. So we'll often have call orders for that too. The Doppler is the tool I think that we use most commonly in the emergency room. This machine has that little ultrasound probe, and that ultrasound probe is actually detecting blood flow in your artery. So there's a bunch of different places that you can use it. You can use it on the dorsal metatarsal artery. You can use it on the palmar aspect of the metacarpals. You can use it on the base of the tail. I know I see people using all of these places commonly. One thing that I think will be helpful for treatment sheets, and many of you do this, is to, when you're getting a blood pressure, especially if you're changing shift and rounding, if you can note where you're getting the blood pressure for hospitalized patients, that's often helpful for consistency and the cuff size that you use as well. So you put this little probe on, you're detecting the blood flow, and then you have a cuff that's attached and is above where the probe is. And then the idea there is that when you inflate the cuff, the Doppler sounds go away and they become audible again when the pressure in the cuff is less than the pressure in the artery. So that number that you're reading is where the blood pressure is in the patient. It can be really useful in small patients. It can be useful in patients with arrhythmias. In general, I would say that it's more accurate than the oscillometric blood pressure in our patients who are emergent patients who are not necessarily stable. The oscillometric blood pressure system is the automated system. So this is one that is sometimes used in surgery and is often used when we go to the doctor to get our blood pressure. It also has a cuff, but the readings are obtained by the machine. So as the cuff deflates, the pulse pressure changes, and that's sensed by the machine. And the thing that's important to remember here is that the oscillometric system is measuring the mean arterial pressure. So it's calculating both the systolic pressure, which is what we usually record, and the diastolic pressure. It will not work very well if a patient is having arrhythmia. So this is another tool that when you're using it, you want to look and make sure the heart rate matches when you're monitoring the pressure so that we know that it's fairly accurate. So like I said, if you're using the oscillometric, check the heart rate. And then also keep in mind for both of these machines, the cuff size is really important. So noting that on the treatment sheet is nice. It should be about 40% of your limb circumference in dogs and about 30% in cats. So if your cuff is too small, you're going to get a falsely high blood pressure. And if your cuff is too big, you're going to get a falsely low pressure. Any questions before we talk about a quick case?
Dr. Beer,
Yeah.
can you review how we handle triage cases when it's a potential infectious disease?
Oh, yes, absolutely.
Thank you.
So did you guys hear that? Jim just wanted me to talk about briefly how we handle cases when they're infectious. And Karen, maybe you can pipe in here too, because obviously you do this on a triage basis more than me. Patients who we worry about infections in. So for example, respiratory diseases, kennel cough, parvo, those guys hopefully are usually triaged to a room, right, Karen? And then we want to go into that room and do an assessment of them in the room before we decide what they need further diagnostically. Obviously, some of those patients are very, very sick. And so if they need to be triaged back, talk to a doctor right away, and we'll either have you triage them into isolation, or sometimes they do need to come into general population to get stabilized. But we do want you wearing personal protective equipment. And ideally, they should stay in the room if they're stable until they can be assessed by a doctor. Do you have anything, Jim or Karen, to add?
Nope, that's it. Same thing with the parvos. You know, we're pretty good at young puppy vomiting diarrhea. We'll put them in a room right away and try to do everything there until we have the parvo status. So same for the respiratory cases.
Yeah. It's funny that you mentioned that, Jim, because there's this hilarious cartoon I almost put in here that was like, ICU doctors going into an isolation unit, and we're like fully PPE'd with all of our stuff on. And then it has a picture of like an emergency tech going in, and they're like Rambo, totally naked, just not scared at all. They're used to seeing all this crap all the time. Okay, so briefly, we're just going to talk about this case, and then we can talk about any more questions. I know you think you know what this is going to be, but it's not. So just keep your feelers open. So this is a case that we saw when I worked in the ICU at Penn. It was a 4-year-old spayed female Great Dane. Her name was Pippa. And she came into our emergency service with acute vomiting and diarrhea and collapse. She had last been normal 4 hours ago, had no pertinent medical history, had not been gastropexied, although she was spayed and was not on any medications. On her triage exam, her mucous membranes were pale with a CRT of over 3 seconds. She was tachycardic with a pulse rate of 220, and her pulse quality was weak and irregular. So this is one, like Dr. Fidel was saying, where you may be feeling her pulse rate or her heart rate over her heart, and her pulses did not necessarily match that heart rate. She did have a normal respiratory rate, but her effort was increased. She was breathing with some abdominal component, and she seemed tense in her belly, and it was slightly distended. She was also just mentally dull, not very interactive for us. She was laterally recumbent, and certainly was a patient who I think we can all agree needed to be triaged right to the back. In terms of further assessment, as we were bringing her back on auscultation, we were able to confirm that she was tachycardic with irregular pulse deficits, and she had abdominal pain. So at this point, we need to decide, what does this patient need for stabilization? And ideally, what additional diagnostic tools can we use safely to try to get us more information? In this situation where you're thinking about how to get a blood pressure, a good argument could be made for a Doppler blood pressure. Because she's having arrhythmias, we know that the oscillometric is not going to be very accurate. And so on Doppler blood pressure, her pressure was 50, which is low, which could mean that she's hypovolemic, like we were talking about. Certainly, I think some of her triage parameters would point to that with the pale mucous membranes and the prolonged CRT. She could be peripherally vasodilated, but in those patients, we would expect to see more red or injected mucous membranes and a rapid CRT. But you also could make an argument that maybe she has impaired contractility, right? She's having arrhythmias. We're noting that on our triage exam. And so maybe part of that is affecting her perfusion and her ability to get blood to her peripheral tissues. This is what her initial EKG tracing looks like. So there's definitely some normal beats in there that we can see, but we're also seeing some ventricular contractions. And there may be a few different causes for that. Obviously, we can see it with primary heart disease, but we can also see arrhythmias in the heart secondary to hypoxia. If that heart muscle is not getting good blood flow, just like any muscle in the body, we can see hypoxia, and that can affect the way that the heart contracts. We also can see it with pain, and it's fairly common that we'll see it secondary to abdominal disease. I would say most commonly splenic disease. It's not unusual for those guys to have ventricular arrhythmias, but we really can see it secondary to any severe abdominal disease too. Her pulse ox is okay. So we're getting 96% on room air, and it's fairly matching her heart rate fairly well. So at least she's oxygenating okay at this point. And then on her minimum database, as we're getting a little bit of blood and getting a catheter in, we can see that her PCV is 62 and her total solids are 6.2 with a blood sugar of 187. So in terms of what we're going to think about there is her PCV is high, right? So that suggests that she has some hemo concentration. But her solids are in the normal range. So maybe we're also having some protein loss. Maybe there's some GI disease there. Maybe this is a situation where she does have a hemoabdomen and she's having splenic contraction. And so her PCV is going up, but the solids are going to be a little bit lower than they should. And she's hyperglycemic, which at this point I would attribute to stress, but certainly it's something that we want to monitor as we resuscitate her. So how should we stabilize this dog? I think we all can agree that we want some fluids to start. Dr. Friedel and I can probably agree we would give this dog a fluid bolus, even with heart arrhythmias, because I think our suspicion would be that the heart is not the primary problem. And then some pain medication too. We know that she has belly pain that could be causing her increased heart rate or contributing to it at least. And generally choices here initially are going to be our opioids. We like them because they're reversible, and also they're fairly cardiovascularly and respiratorily safe. So something like methadone or a fentanyl bolus or hydro, I think would all be reasonable to start. Keep in mind that we would want to use the pure mu opioids here because we can reverse them easily. And if this is a dog that's going to need some further intervention, we'd like to have that on board. Obviously, we need further diagnostics, right? But we want to try to get her as stable as we can first. So in this dog, we started some fluids, we started some pain medication, and then got her down to x-ray. And her abdominal x-rays look like this. Does anybody know what this is classic for? Besides Dr. Fidel? It's not a GV, right?
Is it a mesenteric torsion?
Yeah. So this Dane has a mesenteric torsion where at the root of the mesentery, there is a twist, and the intestines become torsed. And when that happens, they lose their blood flow, right? Because their blood flow comes from the mesentery. So seeing diffusely dilated intestinal loops like this that kind of look like they're stacking is really suspicious for mesenteric torsion. And the reason that this is really a true emergency is because when they don't have that blood flow, the majority of these patients are we either lose them before we get them on the table, or we get them on the table for surgery and their intestines are already severely compromised, and necrotic or black, and so severely and diffusely affected that we can't reset their entire GI tract. So luckily, this dog came in really quickly. We got her into surgery. We were able to untors her torsion. And she did have a small area resected and had an RNA, but actually made it through surgery, which was amazing. And this is her recovering in our ICU. Obviously, she has all of that monitoring equipment that we've been talking about. You can see on her SurgiVet here, we've got her EKG. She's still having some ventricular arrhythmias. She's on a lidocaine CRI. She also has arterial blood pressure monitoring. That's this other waveform that you're seeing here. We got our pulse ox down here. She's got heat support. She's got all kinds of pumps going back here with fluids and all kinds of stuff. She was hospitalized for about 4 days. This was our surgery resident who cut her, and she went home and did great. So that was a really nice success story for us, because many of these patients don't end up leaving the hospital. And I think that's all I have. I'm happy to answer any questions that you guys have. I'll keep the recording on just in case people are going to listen later and they have similar questions. But if you have to peace out and get back to work or do what you're doing, then go ahead too. Thanks for coming.
Before everyone goes, I want to make sure I have a list of everyone that was in attendance today.
Okay, thanks, Kyla.
So I have almost everyone. There's just a couple people, I don't know who they are. So I have iPhone 2.
Speak up if you're iPhone 2.
Anyone claim an iPhone 2? Or
That might be me.
nope,
This is Gianni.
no,
no?
you're Gianni on here.
Okay.
Yep, you're good.
Copy.
Looks like iPhone 2 may have left actually. So
Hey, Kyla.
hello,
Hey, it's Nikki.
you're Tech 10. Got it.
Yeah. Well, Tina and Taylor are watching with me, but
Okay.
is this something? It said it was recording when I logged in. Is this something that we could have the recording sent to us?
Yeah, I don't know, Kyla, how you want to end up sharing it, but yeah, Nikki, we are recording, and I think it is something that we're gonna try to share for people who couldn't be here.
Okay, because we missed a little bit of the beginning and we've been working.
Sure.
So we're kind of on and off watching,
Yeah.
but okay, cool. Thank you.
Cool. And then the one that just says Megan, is that Megan Levine?
Yeah, I know
this
she did
me.
email me and said she wanted to come.
Cool. What about one plus Nord N100?
That might be
Yeah, who is that?
Ashley Geboard.
Got it. Thanks.
Yeah.
And then who's watching from the pharmacy?
Damn. No, isn't it? I think it's Chandler.
Cool.
Hello.
Hello. Is that Brittany?
Oh,
Sorry, crying kids.
somebody gave me a microphone. I think it was Chandler that was in the lab.
Got it. Okay. What about OVRS 28? Who's that?
That's Zimmer's team.
Oh yeah, they sent a little message.
Got it. iPhone 2 is the only one I didn't see.
You got me, Kyla, right, Tracy?
Yeah, I got you.
Did I come up?
Good.
Okay.
iPhone 2, it says I can still see them on here. Let me see if I can ask. Who are you?
I think I have everyone else.
Kyla,
Does
you have me,
anybody have
right?
any questions? Vinny, do you have any questions?
Yes, when can you eat? Um,
Okay, well, if nobody has any questions, we'll wrap up. You guys can always email me or find me in the ICU or find Dr. Fidel. We're gonna try to do, I think, about a CE every month now, and we'll keep doing it over Zoom. It seems like this is a good way to get attendance for now. Obviously, I like doing it in person better, but this is working since we have so many people. And I'll look through and see what we can tackle next. But if you guys have things you'd like to discuss as topics, please let me know too. I hope it's helpful.
Thank you so much.
Thank
Thanks,
you, Dr.
Karen.
Beer. Thank you.
Welcome.
Thank you.
See you guys later.
Thank
Have
you.
a great day.
Thanks. Bye.
Hey, bye.